Hello everyone, and welcome to our webinar on navigating paediatric care in emergency contexts. My name is Alexandra Brown and I'm Medical Communications Advisor at Médecins Frontières Australia. On behalf of MSF Australia, I would like to acknowledge the Gadigal of the Eora Nation, the traditional custodians of this land, water and sea, and pay my respects to elders both past and present. This always was and always will be Aboriginal land. I'd also like to acknowledge those from New Zealand who are joining us as well. Tonight, we're focusing on MSF's approach to providing paediatric and neonatal care in humanitarian contexts and the clinical challenges for our teams. We have a continuous need for paediatric and neonatal doctors and nurses in MSF, and you can see the essential criteria on our slide. In our discussion today, you'll learn a little bit about how some of your peers have come to work with MSF, but please review the essential criteria on our website before applying. Speaking of peers, it's my pleasure to be here with two highly experienced colleagues, Dr. Joanne Clarke and Janine Evans. Jo and Janine, please tell us a little bit about yourselves.
Thank you, Alexandra. So I'm a senior registrar, almost finishing my training in general paediatrics and paediatric emergency medicine. I'm based up in Darwin. So I'm originally from the UK, but have worked in various places around Australia in the past 10 years. And have always kind of been particularly interested in, caring for children in more kind of vulnerable and regional and remote areas.
Janine?
And hi, I'm Janine and I'm a paediatric and neonatal nurse, and my background is paediatric intensive care. I've worked in that for quite a long time and was always very interested in global health as well. I worked with a couple of other NGOs. I spent a lot of time in Libya and Iraq, and then transitioned over to MSF in 2017.
Lovely. Thanks for sharing that as an introduction. And thank you both for allowing us to draw on your deep MSF experience tonight. To those of you joining live, if you have any questions during the webinar, please add them to the chat as we go, and we will address as many as we can at the end. So Jo and then Janine in turn, what drew you to combine your specialty in paediatrics with humanitarian work overseas, and how has that evolved with MSF?
So paediatrics has kind of always been the specialty that I've wanted to do, and I think I've always kind of had an interest in kind of global child health. But I think that was kind of really like the wheels were set in motion when I spent some time in Uganda as a medical student and spent a lot of time on the children's ward there, and just kind of gained more of an understanding of the issues surrounding child health, and some of the impacts on child health and some of the things that can be done to kind of improve health of children, both locally and also around the world. And I was kind of given the opportunity to kind of develop those skills and work in that domain with MSF. And I've worked with MSF since 2021 in 3 different projects in quite different contexts, with some similar but also some very different kind of issues. And it's kind of given me a real broad experience in kind of humanitarian work and issues in child health globally. And not only have I kind of been able to share my skills and knowledge, but I've learned so much from working with the local staff in each of the countries that I've worked in. But also with MSF, I've kind of gained experience in kind of management and leadership, and also had the opportunity to do both informal and kind of formal training programs as well with local staff that I've worked with.
Thanks so much, Jo. And what about your evolution, Janine?
Yeah, so I was always going to be an ICU nurse, and I was always going to be in paediatrics like Jo. So that's where I started my career. And I happened to be really lucky that I had a couple of medical role models where I started my PICU career that were very involved in global health, very involved in vaccination research, oxygen therapy research in low resource settings. And so they really opened my eyes to the big problem of under 5-year-old mortality globally, and how much simple things like oxygen and antibiotics and that really helped. So that really piqued my interest. And then just with personal travel, I'd so often see children with conditions overseas that I knew back home here in Australia were really treatable and manageable. So I actually got an opportunity through my hospital to go and work in India initially as my first ever kind of assignment, I guess, and just loved it, but also could see how much more value I could do it with organisations that stayed in places long term. So I kept working on my skills back home. I really love teaching, really love working with staff and helping them grow and develop. And so when I did actually start working with MSF, I think all my previous assignments I'd done with other NGOs really helped, but also bringing in my teaching skills. And that's something that MSF has also really embraced and encouraged, and they've helped me continue to develop my career in training. So, they've opened up training places for me to go to training courses within MSF, but then also helped me. They knew that that's where I wanted to take my career rather than management streams, even though you always do a lot of management. And so I ended up getting training positions with MSF, and so I've now done quite a few assignments with MSF as a trainer going into different places, and they've really supported me to grow and develop my training skills. And I think, as Jo said, it's just wonderful to work with the local staff and see them grow and develop and flourish.
Wonderful. So now we'll actually talk to how you've worked in some of the projects that you have. And in fact, you've worked in some different countries, but you've also worked in the same MSF projects in South Sudan and Afghanistan. So Jo, you were in MSF's Mother and Child Health Project in Awil in South Sudan on your first assignment in 2021. And then Janine, you worked in Awil just last year. And then the two of you also worked in MSF's paediatric project in Herat in Western Afghanistan in 2022. So we're going to draw on that common ground a little bit. Jo, what are the most common illnesses or health issues that children were affected by in South Sudan, in Awil? And what did you learn about the reasons for this?
So MSF's project in Awil in South Sudan is a big project, kind of, as you said, encompassing maternal and child health. So in the kind of paediatric area, there was, kind of pediatrics, but also some surgical and some neonatal work as well. Amongst the children in the kind of pediatric departments, we most commonly saw malaria, pneumonia, kind of severe diarrhea with kind of significant dehydration, sepsis, and also malnutrition. Janine's picture is of South Sudan, and you can see that it's quite a kind of sparse and dry area for most of the year. So the environment's a difficult environment to live in. Malaria is very prevalent and is seen throughout the year, but there's peaks, related to the season as well. But also, difficulty kind of growing food and other food being available in the market, but also difficulties accessing clean water for drinking, but also for kind of hygiene as well. So all of these things impact a child's health. It's quite a vast area, so not everyone is able to access vaccines, or other kind of preventative treatments may not be available, in things like bed nets to try and prevent against malaria. And also families travel massive distances. They talk about, how many days they've walked to come to the hospital. So unfortunately for some children, they've been sick and, the parents have brought them to medical attention, but MSF was, or is, one of the main healthcare providers in that region. So for some people to actually travel to the facility takes such a long time that unfortunately the children are really unwell at the time that they do kind of get there.
Janine, could you also tell us about the neonatal needs in Awil?
Yeah, so as Jo said, it's a very big project and there's big needs, and they have a lot of deliveries every day and a lot of babies every day. And so we see a lot of babies in our neonatal unit, and probably the most common things we see are things like preterm babies, babies with sepsis, and a lot of babies with birth asphyxia. It's always a big challenge, as Jo said. The mothers often, because they live so far away, don't have access to antenatal care, so often only turn up when there is complications and problems, and they present really late. So often by the time they get to us, the baby's already very compromised and very sick and gets delivered in very poor condition or doesn't even survive delivery. So that's really challenging. And also because the mums don't get antenatal care, when they do deliver, we don't have any idea what gestation these babies are. So they come out and they come out small, and even like term well babies are much smaller than we see here in Australia in general. And when the babies come out and they're small, it's really only our clinical assessment that we can use to assess what gestation they are. So there's definitely lots of preterm babies. There's also lots of very small for gestational age babies because of the mother's health issues and lack of access to care. So we do see that lots of babies. We also see lots of babies with congenital defects, which there's often no solutions to in South Sudan. We know that we can do lots for lots of our babies with really simple things, like just simply good breastfeeding, good skin to skin, oxygen therapy, IV antibiotics, things like that really help the majority of babies. So we can do a lot of good for a lot of the babies, but there's definitely a group of our babies that actually, despite our best efforts, we just can't do anything for them. So it is very common, unfortunately, to see lots of babies die. That's just the reality of being in this environment. Having said that, the vast majority we get to do lots for and get to send them home with their mums, which is really lovely, but have to be a bit realistic about. It can be very confronting at times.
Mm-hmm. And sort of following on from that theme, Jo, as a paediatric doctor and working within a multidisciplinary team, how did you prioritise care in a wheel, considering the high needs? What are some of the limits of care that MSF staff face in a project like a wheel?
So as we've kind of said before, like a wheel in South Sudan, it's a really big project and it employs a lot of, like hundreds of local people in, not only medical and nursing roles, but others kind of supporting roles. And I've had it, in all the projects I've worked in, it's amazing the way that the local staff deal with such huge numbers of patients. I think one thing that MSF does really well is triage. So, they can quickly identify the children that need attention soonest and the ones that can wait a little bit longer. For myself, I was the only paediatrician there and supported by the nursing staff and also a small number of local doctors and clinical officers. So you work really closely with the local staff and you have to kind of learn each other's kind of skills and strengths. And I think something that I've really learned is you have to learn how to delegate and learn when it's something that you need to deal with and when it's something that you can kind of trust other people to deal with. But it is very difficult when there are such high needs. The MSF guidelines are really useful because they are tailored for the resource limited settings and for the things, in terms of medications and other equipment that you have access to. So I have always found them invaluable to knowing what you can do. But obviously, as you kind of said, there's always limitations in what you can do. And that can be a combination of limitations in, your actual resources that you have there, but also the resources in the wider area. So, for example, in South Sudan, there's not really any option for you to transfer children to other places for, any higher level of care than what you're offering locally. So we would see quite a few children with congenital heart disease in South Sudan. And MSF has trained many of the local staff in like bedside ultrasound, and then through the MSF telemedicine resource, those images can then be uploaded and be interpreted. So I found that really useful in these children with kind of suspected congenital heart disease, because although you know that there's no kind of definitive surgery that you can offer for these children, being able to explain to a family, you know, why their child is kind of breathless or not growing, because you've done the scan and you can see what the problem is with the baby's heart, you can then, for so many families, I think they found kind of comfort in knowing what the diagnosis was and what the future holds for their child. And therefore, you know, MSF can then support that family in kind of offering the kind of care and the comfort to the child and the family, and be able to counsel them on the kind of, potential limitations to life that their child is going to have.
Janine, what was most challenging for you and your locally hired colleagues from the perspective of limited resources, but yet again, those high patient needs?
Yeah, so again, looking at somewhere like a wheel in South Sudan, it's already, as Jo said, a very big project. I think there's something like 200 beds or something like that spread across a range of buildings and tents and very spread out. And then it gets really challenging. So in malaria peak season, the presentations to hospital go up by several hundred children a day. And so being able to pull out the children that need the treatment first is really challenging. And then we've also got the ongoing challenges of there's always measles rumbling along and other things rumbling along, and they also can flare up, and you can suddenly have an influx from a particular area of a whole lot of children with those kind of communicable diseases where suddenly we have to find more space for them. So it's really challenging for the local staff to manage that. And, you know, the nurses are amazing. We have quite a lot. We have something like 50 in a wheel. We had something like 50 nurse aides, and I think somewhere between 150 and 200 registered nurses. So it's a massive team, and they work really hard, and they have all these ways to manage all these excess children when they come in, and we have these systems. And, you know, for example, in a wheel, when it's real peak season, we end up with children lined up in the hallway overnight as more and more come in, and then they get reviewed and treated and discharged, etc. The next day, and the corridor clears out, and then by the afternoon the corridor is filling back up again. And that's just the reality of managing those high patient numbers. But the local nurses are amazing. They work so hard in conditions that I don't think any Australian nurse would be able to tough out. So we do lots of work, lots and lots of training with them. They really love and embrace training. They love learning. So we do lots of training to help them recognise the deteriorating child, recognising which children are the ones that we need to give our attention to, and make sure they're moved into the higher acuity areas so we can keep an eye on them and manage them. And lots of training to try and maintain a good level of quality, because just because we're low resource doesn't mean we're low quality. We're still aiming for high quality care. You'll see we do all the things that we do back here in Australia, like monitoring our hand hygiene, monitoring our infection rates and things like that. So lots of training with the nursing staff and, you know, that huge big team to try and have consistent care across everyone and have them working the same. And just like we've got the care guidelines that Jo referred to, we actually, MSF in the last 5 or 6 years has really developed a whole huge amount of resources for nurses. So we now have a whole lot of nursing procedures. So again, we can ensure consistent care and a standard of care for all the children that all the local nurses get trained in how to perform these particular skills. And they do a really great job with that. Yeah.
That's a great point about the nursing guidelines and how much has been developed.
Yeah.
So turning to Herat, turning to Western Afghanistan, and Jo, again for you, what stood out for you in terms of children's healthcare needs there and the challenges for families and clinical caregivers? And it would also be lovely if you could just sort of set the scene a bit for how we're set up in Herat.
So Herat in Afghanistan, again, is I was there in 2022. Yep, and it was a big project, and I think it's kind of grown since then. So we were constantly having to evolve, and it's amazing how much you can build a hospital from shipping containers. And once you're inside, you wouldn't even know you're inside a shipping container. So it was quite incredible how MSF could kind of respond to the increasing needs. And we had a measles outbreak during my time there as well. And, you know, they can kind of put wheels in motion to kind of respond to those needs. One thing that we saw a lot and was a big part of the project in Afghanistan was malnutrition. And this has always kind of been an issue, but I think with the recent changes politically and the economic downturn in Afghanistan, it's made it a lot more difficult for families to access or be able to afford food. And as well, in recent years, the kind of other people who may have been providing support to Afghanistan are not necessarily there. So lots of reliance on MSF to kind of provide healthcare to the local population. We particularly saw a lot of malnutrition in babies under 6 months of age. And then that really kind of made us focus on the mother-baby dyad, because our goal in those children is to reestablish breastfeeding. Because it's something that hopefully is achievable and, is of not needing formula and access to clean water to be able to safely feed your baby. But then this brought in some complications with the cultural difference that you experience in Afghanistan. And it's obviously a very different culture and environment to working in Australia or New Zealand. And we would find that there was often reluctance for kind of young women, like the mothers of these babies, to be unaccompanied in the hospital. But given, the kind of gender culture, we couldn't have dads or other male family members they had set visiting times, but out of those times, it was very much, mothers and children, just to make it comfortable for everybody to be there. But that would sometimes cause problems if family members were not comfortable. So we had a great team of health promoters and nutrition assistants who are local staff. It was a mixture of male and female staff. They, obviously understand the culture, they have the language, and they would do regular sessions, both for the mothers, but also for the fathers as well at visiting time, to really kind of explain to them what our goals of therapy were, the importance of mum and baby staying together, and what we were trying to achieve. And with kind of so many things that, you find in healthcare and other aspects of life, just having good communication and reaching a mutual understanding gets you so far. So really, having that wider healthcare team is so vital to kind of, and having the local understanding as well, which, you can only get from working with local people, just really helps to break down some of those barriers in care.
Yeah. Thank you. Janine, you had a training role in Herat. And what were the key areas of support that you could provide to your locally hired colleagues? And how did that experience compare with some others you might have had?
Yeah, so I was in a training role with a paediatrician, and the pair of us were like in a mobile training role where we would go to different projects and deliver training. So there's a couple of specific trainings that we were delivering. So one was paediatric emergency hospital care, and the other was neonatal hospital care. So they're trainings that go for about 5 days in the classroom. They're very interactive. They're, I suppose, an APLS style. For a lot of our people listening will be very familiar with APLS courses. So really interactive, lots of case studies, skills stations, we do simulation, all these kind of things over the 5 days. And we really spend all that time, it's all about emphasising the MSF guidelines, so really making sure everyone's really familiar with the guidelines and can practice them. And we really work hard to get a really systematic approach to how they approach the child. So the A, B, C, D, E is something that we really emphasise a lot with the staff, so they approach the children really systematically. Harats was a little bit different, because normally what we do, as I said, is we go in and we do the classroom for 5 days, and then we'll go and spend at least a week on the wards, working at the bedside with the participants from the training and helping them implement what we did in training into their work. But in Harats, in Afghanistan, because there's a lot of security constraints there, so it's very controlled as to how many MSF staff can be in a project at any one time, how long we can stay there, those kind of things. We were only allowed to be there for 4 weeks, and we were running 4 weeks of classroom training. So in Herat, we didn't get to go into the clinical area, which was a shame. We just did the 4 weeks of classroom, which was great though, because got to have lots of fun with the nursing and medical staff. The training is a combination of medical and nursing staff in all those trainings, because we're trying to mimic how they work in the real world. And so we're also working a lot on their behind the scenes on their communication skills and teamwork as well, to help them interact better in the workplace. And that tends to go down really well, and they're often quite surprised. They often don't spend a lot of time together, the doctors and nurses, because of either hierarchical issues or gender issues, depending on the cultures you're in. Just as a side issue, in Yemen, we had to get special permission to have women and men sitting in the same classroom together. So there's always those kind of challenges, but they got so much benefit from it. I've just found out that in Afghanistan, in Herat, I'm known as the ABCDE nurse, because that's what they remember me really pushing in training. So I'm glad that message got through, and 2 years later that message is still there, and hopefully they're doing it. And then some of the other places that I've done training, like, for example, in Bangladesh, it's very relaxed and open and safe. So when we're not training, we can actually go down to the local shops, go to the local cafe, go to the beach on our day off. But in Herat, in Afghanistan, we were pretty much between the hospital and the compound we lived in. That was the life. There was a little bit, we could get out a tiny bit. There was one market we were sometimes allowed to go to, and there was a mosque we were allowed to go visit when I was there. I don't know what the security conditions are today in regard to that. But yeah, it's great fun with the locals in the classroom. And by the end of it, by the end of those 5 days, we're all really good mates.
A lovely anecdote. Jo, so the title of ABCDE, I don't know, Queen, is that it? Has already been taken, but what might you be remembered for in a project, in a wheel or somewhere else?
I'm not sure if I got a label for anything, but I would often come into the neonatal ward and see everyone scurrying around, because I was really trying to promote them putting like name bands on the babies. I have never seen so many twins in my life as you see in South Sudan. And sometimes just one of the babies would be unwell and be needing antibiotics. And often the babies did not have name bands on. So then there's always the trying to work out which baby is which. So I was really like, we need to label these babies. So yeah, so I heard that, they'd see me coming and then they'd be panicking that there was some new twins born overnight that hadn't been labeled yet. I think there was one time when they couldn't find the name bands fast enough, and they just found some tape and just wrote baby 1 and baby 2 and stuck the tape on the baby to try and make sure I was going to be happy that we knew which baby was which.
Yeah, that's funny. So Janine, I've got a question about how we sort of integrate care for women and children in MSF, and a newborn's health is intertwined with its mother's. And could you explain how this dynamic and how MSF responds to it?
Yeah, sure. So as you said, we know that the mother and the baby's health is completely intertwined, and that if we can keep the mums in really good health throughout their pregnancy. They're much less likely to have babies that are preterm or born with other complications or experience birth asphyxia. So MSF does a huge amount of work with the women and the communities around trying to improve the women's care. So there's a lot of like health promoters and community engagement to educate the community and the women and also the men, because often the men are the ones that control whether the women can access healthcare. So we do a lot of community work just to engage and educate why there's a benefit of them coming to even see MSF for antenatal care and as well as having their babies with us. And then there's a whole lot of work we do. So, for example, with the antenatal care, it's keeping the mum in good health, giving her vitamins, preventing anemia, testing and seeing if they've got things like malaria or sexually transmitted infections that we can treat. They're all going to improve the baby's health. Training the mums and their female relatives around the danger signs in pregnancy. So helping them recognise when they need to come to MSF and get help, so we can help them before the baby experiences complications of that, and even just support for their mental health. We do a lot of work with contraception. That can change from country to country and project to project, because sometimes there's, in countries like, I think when I was in Yemen, we were restricted around what we could do with contraception, but in other places it's very accepted. And that's really important, because if we can help the mums have a bit longer gap between pregnancies, that allows them to, again, be in a better health situation for their next pregnancy. If we can reduce things like teen pregnancy, again, that's a really high-risk group for having complications of pregnancy and delivery. So, again, we can protect the babies that way and the women that way and prevent them experiencing complications like fistulas. And I've worked in projects where we do have big fistula clinics. Again, having trained skilled birth attendants, so these women are giving birth in a safe way, in a clean way to prevent infections, and people that can recognise complications and get the women into our MSF site so we can help them. Like, for example, in South Sudan, we do have the ability to do caesareans and things like that to help save the women's life or the baby's life. And then just our whole neonatal care area is so important for helping these babies. So once they are actually born, like being able to do a lot of things we can do, like I said, like a lot of effort goes into breastfeeding and feeding preterm babies. Sometimes we're doing a lot of cup feeding or even nasogastric feeding if they're too small to be able to suck and swallow. A lot of skin-to-skin care. We do a huge amount of skin-to-skin care because we know that improves baby survival. We have a zero separation policy in MSF where we work really hard to try and keep the mother and baby together if the baby has to be hospitalised for health problems. So, for example, in a wheel, our neonatal unit is actually all adult-sized beds that the mums are on with their babies on the bed with them. Some other projects, we haven't got as much space, so the baby will be in a cot and the mums will be in a building nearby where they stay and can come in and out and feed the babies. We supply the meals to the mothers while they're in the hospital. So again, we're trying to keep them in really good health, well nourished, so that they're able to breastfeed their babies successfully. And probably another thing we do that's super important is we give them a statement of birth. So a lot of the countries we work in don't have functioning registries for things like births and deaths. So when MSF gives the family a statement of birth, it's proof that their baby's, born here, born in South Sudan, and they're a citizen, and it can open up, openings to social security and different things like that they might not otherwise be able to access. So, yeah, the care of the mother and the baby is integral, and we have to get the mother's care right to make sure our babies are in good condition and less likely to suffer medical conditions.
Thank you. That was a really rich explanation. Jo, MSF is applying a planetary health perspective to some of its newer programs. So how would you describe your contribution as a paediatrician to this on Kiribati as part of MSF's project? and what we're doing there?
So as you said, I think we're becoming more mindful of planetary health, and a lot of places that MSF work, it's countries that are particularly vulnerable to kind of natural disasters and the impacts of climate change, and these have an impact on the health of the population. And as we see, increasing problems with climate change, then we can only expect that that's going to impact the health of the population in those countries. So I spent 6 months in Kiribati last year, and it's a very remote country in the middle of the Pacific. And, they are faced with issues with overcrowding. They have difficulty being able to grow their own produce, and also difficulty with access to clean water. And these issues are only going to get worse with rising sea levels. They already have such a small land mass already that, they really can't afford to lose any land to rising sea levels. So we saw a lot of malnutrition and, again, like kind of diarrheal illnesses there. But they're impacted by their kind of remoteness and their environment. It's really difficult to get resources there. But also what they really struggle with is access to kind of training and guidelines. They can locally train nurses, but they're not able to train doctors. So all the doctors have to leave Kiribati to go to medical school, and then they come back as interns. But very few people are able to access any ongoing training. So, as well as providing kind of clinical support in Kiribati, a lot of kind of my role and the role of MSF was capacity building in the local staff, both in medical and nursing staff, and, kind of helping them implement MSF guidelines, and also helping with training. And again, using a lot of the newborn care training resources and implementing a kind of formal training pathway, both for the nursing and for the medical staff, I think will be really kind of integral in improving the health outcomes in children there, by just kind of improving people's kind of understanding and training on how to look after these babies. And as Janine touched on before, it's often such simple things that don't require many resources, but if you do it well, it can have make a really big difference to these babies.
I don't want to put you on the spot, but I'll just throw this question at you. Can you describe either a typical day or a memorable day? Do know, Janine, you have your first day on your first assignment, which actually was a day to remember. But yeah, and maybe we start with that, because it was an impressive day for you and memorable, as I've said. So please share that story.
Yeah, so my very first assignment with MSF was in Nigeria, up north in a place called Jahun, which was, again, a bit like these pictures of South Sudan. You can see it was very remote, very dry. The population there are very poor, live in mud huts, itinerant farmers. And so I was sent there to work in the neonatal unit to help improve the nursing care there. And so I walked in on my very first day ever with MSF, and the first thing I walked into was a resuscitation of a baby with birth asphyxia. And yeah, it was extremely, extremely confronting to walk in and see them resuscitating this baby. And the baby didn't survive. So I was a bit like, what have I walked into? Because in the next cot was a baby that was had seizures that were like not responding to care, and the maternity unit's next door, and we got called to the maternity unit several times as well, every day to resuscitate babies. Very common for all the reasons I talked about earlier, women presenting late and with lots of conditions, and these babies often come out in very poor conditions. So yeah, my first day was very confronting and really made me realise what I'd walked into. I think we were talking a little bit about limits before, and I think probably again to say here, just for everyone to know, is that just like In Australia, in MSF, we do have guidelines around resuscitation, and we also have the guidelines include when we need to consider that it's time to stop the resuscitation. There's limits there, and therefore a reason, just like here in Australia, we know that prolonged resuscitation isn't good, and it just can result in babies surviving with really significant disabilities. And that becomes even more so in MSF settings because we don't have ICUs to do the care that we would do here in Australia or New Zealand for a baby that had survived cardiac arrest. And these countries just are not set up for children with disabilities. There's no support structures. Like, you can't send a baby home with nasogastric feeding. There's just no options for that kind of thing at all. So that's really confronting to see a lot of babies needing resuscitation, and that quite a few of them we need to stop because we've reached that point in the resuscitation where there's nothing more we can do. So really, really confronting, very memorable first day. But I must go on to say that I was there for 3 months. I was a wonderful team in the neonatal unit, and they were amazing. They were so responsive to training. They improved so much over that 3 months, and it was, despite that confronting first day, it was wonderful. And I actually was lucky enough to go back there again last year to do some training, so 6 years later. And a lot of the nurses that were junior when I was there in 2017 are now the senior nurses in the project, and it was just so lovely to see how they'd grown in the 6 years. And they were so proud to show me the renovations they'd done in their neonatal unit and some of the improvements they'd made over time. They were just so proud, and they were doing such a great job. So, yeah, very confronting first day, but amazing experience overall.
Yeah. Thanks for sharing that. Jo, what day are you going to pick?
So I could probably talk for days sharing stories about my experiences with MSF. And, you know, for every kind of good story, there's obviously bad stories as well. So, you know, it's obviously a very difficult place to work. But one thing that really stands out for me, and I don't know if Janine actually knows this story, because it happened on the day that you were leaving Herat after you'd completed the training. Because I remember the paediatrician who'd come with you for training was there at the time. I think he had to leave for your flight during the situation. So the local staff had just completed the 4 weeks of kind of emergency hospital care training, which, as Janine said, you know, is kind of a APLS style training, but really tailored to kind of those more resource limited settings. And a child was in the emergency department of our area of the hospital and had an anaphylactic reaction to an antibiotic that was given. And the team kind of started resuscitation. They used their ABCDE approach that they'd have been taught by Janine. And, you know, I think through doing the training as well, they'd really reconsidered. We had a resuscitation area with 2 or 3 beds, but they've really reconsidered the, you know, where all their equipment was. We talked about allocating roles so that, you know, sometimes, I mean, it happens everywhere when there's an unexpected resuscitation, it's chaos. But just having some of those things in place just really helped the situation. So, you know, they were able to do their ABCDE, they were able to start resuscitation, and the child needed a full resuscitation. You know, they were able to make use of the intraosseous needles that we had for access. And I think to all of our surprise, we were able to successfully resuscitate this child. And I always remember them coming to me, like, it was just such a great outcome. And I always remember them coming to me an hour later being, Dr. Joanne, the child is crying because he wants a sandwich. Can you let him have a sandwich? Because I was being the mean doctor that was like, don't feed him yet. So I think it just, you know, like, you always have to take those wins because there's a lot of kind of sad experiences. But I think when you see, you know, the growth and development of the team and the impact that's having on, you know, the children and the families that they're caring for, it's times like that you just, you know, you realise what a great impact that, you know, MSF as a whole is having in that population.
Thank you very much for sharing that story. Jo, I've also got a question for you about just the management component of your work as, you know, an international staffer going out as a paediatrician. Yeah, is there anything you can talk to about that?
So each project will have slightly different structures, and the paediatrician is typically a clinical role, and often there will be like a medical team leader or a medical activity manager as part of the project. So in projects that I've been in that have had those, then sometimes it's kind of a shared responsibility, because you are the person who is on the floor working really closely with the local staff. So you do build up those relationships. But there's times, for example, in Kiribati where we had a slightly different structure. So I did take on some management and leadership more from things that I'd kind of recognized. So trying to have, and I think quite often it's things that you do in day-to-day work at home, and things that you've just grown up with that you just don't realize until it's absent how important these things are. So, just things like rostering, deciding who's going to do ward round, who's going to go to clinic, just those kind of aspects, making some decisions about, who do you call for help and when do you call for help? Yeah, a lot of it can be kind of ad hoc, but often the medical staff who are in the kind of management positions may not be paediatric trained, so therefore they'll kind of ask you for some kind of support on some of the more technical aspects of the management area as well. But I've always felt very well supported by those kind of more senior to me in the project, and have always been able to kind of ask for advice around those issues.
Yeah. Janine, what would you describe as your steepest learning curve in MSF through all your experience?
That's a good one. I think probably a couple of things. One, just getting familiar with the local conditions that are things we don't see in Australia. So seeing a lot of children with malnutrition and becoming familiar with there's a whole regime of how we manage a child with severe acute malnutrition. I mean, it's all there in the guidelines, but just because it's there on paper, the local staff were actually the experts in it, and so I could work with them. They would have their ideas, and then I could. Often what I was bringing in was more the quality layer of making sure that we were being consistent in applying the guidelines, consistent in how we were doing things. Like I had to learn about all the different the formulas and that we use for managing malnutrition through its different phases. And then, it's the little things you find, like there's a very specific spoon that comes with the tins that you have to use. And then I found in one place they weren't using that spoon, which meant we weren't making the formula correctly. So it's often that overview that we're bringing to the quality of things and making sure things are being done consistently with guidelines. So that was a huge learning curve. Learning to manage children with malnutrition. And then I'm now an expert on recognising measles rashes, so that was something new. But I think as far as the clinical care, it's the same as Australia, it's just in a limited resource setting for your standard conditions. But I think the locals, I learn huge amounts from the locals. Yes, I bring my paediatric and neonatal expertise. Yes, I bring my training expertise, my quality expertise, some management skills. I have done nursing activity manager roles on some of my assignments. But the local staff, they know their local conditions, their local diseases, and I learn a huge amount from them. And one of the things that I really appreciated was going in and being open and curious and just learning from them as well, and finding out why they did things the way they did before you decide that no, that's not how it should be done or anything like that. That's not what I'm coming to do. But yeah, I think the local staff are amazing, and we learn just as much from them as they learn from us.
Jo, I'll ask you the same question, and also remind people who are with us tonight that they can ask some questions if they want to, because we've got a bit of time for a Q&A. But yes, in terms of that steep learning curve, is there anything you'd pinpoint for yourself in your experience in an MSF project?
There are so many things that are a steep learning curve. And yeah, you see similar conditions, but usually in kind of more severe than what you would see back home. But yeah, also new conditions like malnutrition and TB. What is my steepest learning curve? I think I would say learning to manage children kind of outside of your comfort zone. So I think when you are trained in Australia or New Zealand, you become so used to having access to whatever investigation you want, really. And it's different in different places that MSF work. But for example, in South Sudan, which was the first place I worked with MSF, you are very, very limited as to what you have access to in terms of investigations. And you really just learn to trust your, kind of clinical assessment of the situation to decide what you need to do, and, just use your own experience and assessment and kind of instinct to know how sick is this child. And I think I have then, having come back to Australia and worked, I'm probably the person who is least likely to order the different investigations and then get quizzed as to why I didn't do this, that, or the other. And I think you really realise that actually having this number doesn't always make any difference to your management. And I think you really grow as a clinician in your, your history taking and your examination skills, and using those. Plus, as you said, kind of getting that local knowledge. And you'll often find that the local staff will just tell you, this child's got this, because they've seen it before.
Thanks. Thanks so much for that. We're joined now by Philippa Arnold from the International HR team as well. And as I said, we've got some time left for some questions. So anyone who's watching us live, please feel free to share a question. You can pose it to people individually or just throw it out there. And so, great, we've got a question from Karina. What prior experience did you have which helped you on your first assignment? So we'll start with you, Janine.
I would say definitely 100% was the fact that I'd already worked with some other NGOs in the settings weren't quite as low resource as they were with MSF, but they were definitely constrained resources. They were high security contexts. So in Libya, we had war outside the hospital all the time. So very challenging from a security perspective. And I think that set me up a lot as to it already put me in the right mindset for when you go into these low resource settings, how you need to be able to think outside the square. You still need to do high quality care and follow your protocols, but sometimes you need to think of different ways to reach the end result that you're trying to reach. They also taught me the joy of working with the local staff and how much the local staff know their own contexts. In Libya, they used to tell me all the time, don't worry, Janine, it's only a little war, it'll be over by lunchtime, and it would be. But I think also having worked in PICU for a long time, even though that's a very specialised area, actually in PICU we see children with every condition under the sun, and we see all the common childhood illnesses, your respiratory conditions, your gastro conditions, all the typical conditions that you see in children, and then your more rare ones, and we're used to looking at really sick kids. So I think that helps. I think also, I've always been a bit of an outdoors person, so I think being comfortable being uncomfortable is really important. In a wheel it was 45 degrees every day and we don't have air conditioning, and it's the living conditions are a little bit more basic than they are in some of the other MSF projects. So I think you need to know yourself and be prepared to be a little bit uncomfortable as well. And I think I've just gone off on a tangent and maybe not answered that question, so sorry.
No, the question was, and I'll repeat it for Jo's benefit, what prior experience did you have which helped you on your first assignment?
No, I definitely agree with the kind of more broad answer that Janine said as well. I'd actually written down being uncomfortable in my little notes just then. So unlike Janine, actually, my first assignment was my first time working in a kind of humanitarian context. So I'd had some experience as a medical student, but this was my first experience as a doctor. In terms of my kind of previous clinical experience that I think helped me, I think I'd always kind of had an interest and had done a little bit of kind of, self-directed learning around kind of global health. But again, I think actually having the experience in paediatric intensive care, neonatal intensive care, but also doing retrievals, I think really gave me that good grounding in recognizing and managing a sick child. And also, having done retrievals, also looking after sick children outside of your typical hospital setting. So although, I still had access to a much higher level of care than what I was able to provide in South Sudan, I think just having that experience in kind of more critical care settings just gets you used to recognizing sick children and learning about the kind of more simple things that you can actually do to improve a situation. So I'd say clinically, I feel like they are important experiences that you can get kind of in your home setting. But I think from a more broad kind of aspect, I think being an open-minded person and remaining curious is so important because you're going to go to environments and contexts that are going to be like nothing you've ever experienced before, and you have to, as Janine said, you definitely have to be comfortable being uncomfortable. And I would say I was uncomfortable in some of my experiences, but I think being someone who is kind of adaptable and can get on well with people and kind of adjust to a situation, is willing to kind of learn from people and take on advice, take on the knowledge that local people are trying to share with you. If you're someone who can do that, that's going to help you so far along the way.
Thank you to both of you for that answer. There's a question also again from Karina. So for Philippa, in regards to recruitment, what is the expected time frame from sending an application to being deployed?
So I guess part of the recruitment process is the pre-departure training, which takes place over 3 days. I would probably say, depending on your availability, you're probably looking around 6 months. But there's also conditions around visas. Janine, you mentioned Yemen. I don't know what your experience was, but the visa for Yemen can take a very long time. And so it really depends on the context that you're being sent to. But I would say that 6 months is a good benchmark to kind of aim towards once you submit your application.
And we have a Kia ora from New Zealand. So we're about to hit the hour, but have we got time for a couple more questions? Okay, well, actually, it's to both Jo and Janine. So, kia ora, fascinating to hear the stories and experiences. As medical staff, what level of training would you recommend before applying to MSF? And are there any courses you would recommend prior to applying to MSF for training in malnutrition or emergency management or suturing, for example? Janine?
Yeah, so thanks for the question. I would say in regard to training, I did my master's in public health. I know a lot of other people in MSF will do tropical medicine. In my public health, I did tropical medicine, infection control, refugee health, and a few other things that were really super directly related to things I do in MSF, and that was very important. It taught me to understand the global health model and how everything works and where MSF fits into that, but also taught me, like, you know, introduced me to a lot of the tropical disease, the diseases we see in MSF settings. And they're not just tropical diseases, they're, you know, non-communicable diseases as well. That was super useful. In regard to experience, I'll let Jo talk about from the medical side. From the nursing side, I think you want to get exposed to a few different things like medical, med-surg, try and get, like, even if you can just get some in-charge shifts as a nurse. So you're getting some skills at managing staff and managing rosters and things like that. If you do some preceptoring and mentoring of other nurses, so you're building your training skills, they're all super important. In regard to training about malnutrition, there's often lots of really good things like WHO have lots of training modules, Sphere has lots of training modules. There's lots of training modules out there. For me, myself, I actually learned on the job using MSF guidelines and talking with the more experienced people in the project to learn it. But there's a whole world of really good online learning resources out there. And actually, MSF also has an online learning system called Tembo that also has lots of really good training modules around things like malnutrition to help as well.
And Jo, what about you in terms of recommendations for, you know, the level of training and what courses someone might do?
So I can't recall the actual criteria for MSF in terms of pediatric doctors, but I believe it's available on the website. But for me personally, I had been a doctor for about 10 years, doing pediatrics for at least 5 or 6 by the time I went on my first assignment with MSF. So I think it's important to be in a position where you have got some experience behind you, that you have some kind of confidence working independently and have a kind of good grounding in general pediatric and neonatal care. And I think it's vital that you, especially in neonates, that as a pediatric doctor, that you'll have done a NICU, spending time in NICU in a NICU rotation. And I think kind of some emergency experience as well. I would say in terms of other things to kind of prepare yourself, I did, you know, access a lot of the online resources that Janine kind of mentioned. There's so many online things that you can do now, and especially WHO is a good resource. I had access to all of the MSF guidelines in a PDF. And as I went on my first assignment during COVID, I had 2 weeks in quarantine where I was able to read, you know, cover to cover the MSF guidelines. And I think that just really put me in good standing for getting started. And then, I also use Tembo. I think there's a pediatric course, and there's kind of neonatal ones now, and I think it's always evolving. And those courses are often on Tembo are often based on the MSF guidelines. So I think, you know, having that kind of solid grounding in your experience to start with, and then, you know, really familiarizing yourselves with the MSF guidelines is, you know, so then you know how to put into practice the skills that you've got in that setting that you're going to be working in.
Philippa, is there anything you want to add about?
I think Jo covered everything. So
yeah, fantastic. All right, so we're going to end the webinar there. Thank you, Jo and Janine, and then Philippa for joining us at the end, for sharing your insights and experiences. For everyone who has joined us online, remember that all the details you need to know about working for MSF are available on our website. But we thank you, all of you, for joining us tonight, and have a good evening.